So nice to see you. Many of you know myself. Some are my patients, so I'm very proud to be here today. But anyway, as has been explained, I've been working at Endocrinologist Street for many years. Actually, I came from Italy 13 years ago, and then I worked as a fellow elsewhere. I did a PhD on hypothalamic injury, and then I've been working as a consultant for the past few years. This works right. That's the magic button. Okay, so hopefully I'm gonna stay on time. So in the next 10-15 minutes, I will be talking about three things. Number one, what is hypothalamic injury? I'm sure most of you know, but it's always good to refresh. Why does it matter to brain tumor survivors, and can actually it be avoided? So on the first point, so the hypothalamus is so important that he made it on the big cover of a science journal in 2023, and they call it the small and mighty. It is a very small area of the brain, but it is extremely important, and without the hypothalamus, we wouldn't survive. Is this a laser? Yes. So as you can see, the hypothalamus controls the most important functions that keep us alive, like such as eating, sleeping, social interactions, and thermal regulation. To be more specific, the hypothalamus is made up of many different nuclei and regions, very complex internal anatomy and cellular function, as you can see, and controls the pituitary gland, which is the gland that is the central post office, as Helen was used to say always in clinic, sending messages to all the organs we have in our body, all the glands that in turn produce target organs. So this is the endocrine function of the hypothalamus. It is an endocrine organ. However, the hypothalamus has also more complex function connected with the rest of the brain, and it controls things such as memory, sleep, behavior, very complex function. Of course, not in isolation, together with other regions of the brain. So brain tumors, as you heard, can arise within the hypothalamus or in area proximal to the hypothalamus and then invade the hypothalamus as when they are big or more invasive. Mostly we are talking about benign brain tumors in histology, with the exception of some of the germ cell tumors and some high-grade astrocytomas, the commonest being optic-pathway-gliomas and craniopharyngiomas. However, if you have a tumor in the pituitary, for example, which is very big, like secreting adenoma, it might actually invade the hypothalamus and give hypothalamic symptoms. You heard enough that the survival rates in these benign brain tumors are high. Why is the behavior of these tumors malignant? Because they arise from the most important region of the brain, of course. And the other issue is that they tend to regrow multiple times in the same regions. Only a very small minority of cases can be completely resected, and then multiple interventions are required, and therefore the injury becomes cumulative, essentially. And no surprise, there is high morbidity and reduced quality of life. We heard very nicely, from our, adult. It's so nice to have adult, survivors in the room, telling their experience. Okay, so location is important and regrowth is important. I will make two examples of craniopharyngiomas and optic-pathway-glioma. On the first, of course, if you have a craniopharyngioma which is arising only in the pituitary, there is less hypothalamic dysfunction. Normally the surgeons like to resect, this region completely. The sacrifice is that multiple hormonal medications are needed for the rest of the patient's life, but in a way it's more treatable than severe hypothalamic dysfunction. If you have a tumor which is complex and cystic solid, and then it's invading the hypothalamus and it's all over the place, you can imagine there is a difference in symptoms there. However, unfortunately, these tumors don't stay still. This is one of the patients at Great Ormond Street under Dr. Gan, and essentially these tumors tend to regrow multiple times, and we have patients who have needed to have 15 cyst aspirations through, childhood. So it's not a static, tumor. What about optic-pathway-gliomas? Similar discussion. So if the tumor is only on one side, in the optic nerve, is obviously more localized, but if the tumor is invasive and is, going all the way inside the hypothalamus, it's a different story. Differently from the craniopharyngiomas, because these tumors arise from the eyes, they are not totally resectable, never. So multiple lines of treatment may be needed if the tumor grows, over and over. And this is one of my patients who has had more than 13 lines of treatment since infancy, as she's now 14 years old. Okay, why does it matter? So it matters because hypothalamic injury is incredibly complex and involves multiple domains. So on one side, you have all the hormonal dysfunctions, and this is many things. I mean, I think you explained, very, very well. I don't need to repeat, but it's not easy to take 5 different types of medications, be at risk of adrenal crisis, have increased thirst, wake up at night to urinate, take all these tablets, and then crack on with the rest of your life. So I think sometimes, hormonal dysfunction are considered easy because you can replace them, but in the daily life, that's not easy for the patients at all. Then you have your appetite problems, incredibly difficult. Some of you know that, and this will lead to long-term problems in adult life. Then you have the sleep disorders we heard, just before, and the fatigue. I mean, the fatigue, I wish I could make it, bigger to encompass the whole slide. It's so multifactorial. It can be narcolepsy, it can be hormonal, it can be cognitive fatigue. It's the vast majority of brain tumor survivors will experience, this symptom, and it really requires a team, to sort of, tackle this problem. Some patients have temperature dysregulation, more rarely. Learning difficulties, they are very specific. It's not global developmental delay. Usually it's an uneven profile, as we heard from Jenny. Normally verbal skills are preserved, so you don't actually realize, the difficulties that the patient is experiencing because they can compensate on verbal, skills, but they have memory and processing speed, issues, and mental health. I put it there, but it's everything, essentially, our identity, as Jenny said. And then, of course, there is going to be the visual impairment, which is not going to make any of the other domains, easy. So how does this practically, look like, when I see the patients in clinic, and what are you telling me? So one patient can say, actually, I cannot finish my day at school. It's too hard. I need to nap multiple times. Some may have actually narcolepsy. I fall asleep when I'm talking, to people. I'm constantly yawning. I cannot follow what you're saying. I'm too tired, all the time. I remember one of the patients after proton beam therapy told me, for me, life now is like walking in the water. I feel like I need to go against the tide, all the times. Everything is heavy. Everything is incredibly difficult for me. Food. Some people can just think about food. It's an obsession. They cannot plan anything else in life. Some others actually don't have hyperphagia, but they try to lose weight, very, very hard. And, there are some people in the room that are doing sports every single day, and it's very difficult to maintain even just the weight they already have. Sleep, we heard extensively. Some people struggle falling asleep. Some people wake up. Some people sleep during the day. Some people have to wake up to wee, multiple times. It's a big, huge thing as well. Some people worry about fertility. Will I be fertile, in the long term? Another question I get all the time, there is neurodivergence. It's very common in the population, but it's commoner in brain tumor survivors. Am I autistic because I have a brain tumor? Do I have ADHD because I have a brain tumor? And I don't think anyone can certainly give you the answer to this question, but because the hypothalamus controls some of these pathways, it's very hard to say it's completely, unrelated as well. Some people struggle with social skills. I have families telling me my son cannot make any friends. The other siblings can. Why my son struggles with that? Because the hypothalamus produces oxytocin, which is our hormone, related to social bonding. And then, people don't understand this. It's invisible. Most people will see maybe the overweight, or if you're wearing a stick and you're visually impaired, all the rest people will not see. And the problem is that when children present acutely with raised intracranial pressure and they have to have, the compressive surgeries, they actually do not realize all this at the beginning. It's very hard to have a full discussion with the families in an acute situation about the future. And then when they come and see us over the years, I had the patient recently and he said, I didn't realize my life was going to be like that. I thought I was going to have surgery and that's it. And then, it was going to be over. So 90% of the mid-brain tumors will survive. More than 50% will have the tumor coming back again and again. More than 50% will develop, neuroendocrine and hypothalamic problems. And this is what impacts quality of life, but also long-term survival. So specifically on quality of life, and this is some of my unpublished PhD data. Of course, this is a questionnaire. This doesn't reflect, your quality of life in the everyday life, but in medicine we use this measure so we can compare, our data with other people who have done similar types of research. But essentially, when I measured the quality of life in a group of patients with different space-occupying lesion, the number I got was this 52. So the lowest, the more impaired your quality of life. So to have an idea, age-matched pediatric controls averagely score 82. So it is not surprising, of course, that most patients with brain tumors will have an impaired quality of life. You can see there is not a single patient that actually reaches, the healthy control cutoff, if you want. But what I failed to realize is that when you compare this quality of life questionnaires with other chronic pediatric conditions which have similar issues, for example, obesity, all type of cancers clustered together, psychiatric disorders, actually it was below all of these conditions, and it was actually very similar to those of children with cerebral palsy. And this itself says that this is a brain injury. Of course, these tumors are different from all other types of tumor because they happen in these vital regions of the brain. Now, I'm going to say something a little bit controversial, especially when there's been, lots of emphasis at the beginning of this conference, around preserving vision and how important visual pathways are in early life for our learning, etc. So in this population of complex tumors arising in the middle of the brain and involving the hypothalamus, then I looked what are the key factors that actually reduce quality of life. Okay, so the most important was behavior, mood, social skills, all the things Jenny talked about. Okay, mental health, if you want. Okay, these are the ones that lower the most quality of life. Gonadal function was important, hypothalamic, appetite and sleep, learning difficulties. Among treatment strategies, radiotherapy was the one most affecting. This is not necessarily because radiotherapy is the baddest of all the treatment strategies. Normally it's given at the end in the most aggressive tumors. But actually, visual impairment comes all the way down as a protective mechanism. Now, I'm not going to say that people who have visual impairment have a better quality of life, but in the context of these very complex symptoms that I've just described with multiple issues, actually, children can adapt better if the tumor is more peripheral and only involves the optic nerves, for example, than if you cannot remember things, if you cannot make friends, if you cannot actually function in your daily life. And of course, most of the treatment strategies really focus on preserving vision, of course, quite appropriately, but this is, something I want to put there for reflection. Okay. All right, so can it be avoided? So there is some degree of hypothalamic dysfunction that we cannot avoid because the location is there, and if you look back, it's been there for a long time. We don't actually know when these tumors arise. We know only when they present acutely, but we can try and make efforts to limit, the further damage that can be done. So how? I mean, this is already happening, and it wasn't happening 20 years ago, but discussion around hypothalamic injury needs to happen in the context of, MDT settings. And of course, it's a very complex discussion. I'm not going to say something very general because it's not going to apply to all of the patients, but the discussion is, can we protect vision without avoiding, further hypothalamic damage, avoiding further neurocognition? What is the effect of different treatments? And also the family, of course, needs to be involved in this decision because it's much easier for the families to think, I want my child to preserve vision, than actually think about the long-term hypothalamic dysfunction. Who understands that? It takes years, to understand that. It's very tricky. And then also this needs to be a research priority because we cannot just talk about survivals. I mean, we heard about that. So if there is a novel oncology trial, we need to find a way of measuring the degree of hypothalamic dysfunction. And at the moment, it's not there because it's very difficult to quantify. Of course, better resections are essential because that's how we can prevent, further hypothalamic damage, the expertise of the neurosurgeons. Kinder radiotherapy, this is what it was attempted with proton beam therapy. We are still awaiting for strong data to see that it was better than the previous photon therapy. There is patients, and this is my last slide, there is penultimate. There is patients who actually have hypothalamic damage, and unfortunately we cannot prevent it, okay? Because that's where the tumor has been arising. So what can we do? We can understand it better. We can look at the mechanisms, why this happens, your child specifically has a risk of this or that symptoms, so we can look for interventions, much earlier. We need to be able to see hypothalamic damage on the imaging, look for novel markers. This is what I've been doing during my PhD. And of course, we need to do what we're doing today, talk about it, raise awareness, so everybody can make an informed decision. Treating hypothalamic dysfunction, we got much, much better, I have to say, than, again, 20 years ago. It doesn't take a single person. It takes multiple people, sleep specialists, neurocognition, rehabilitation, OT, endocrinologists, and all the rest of the disciplines, together. But things can be done now if you make the appropriate diagnosis. It's not perfect. There is a lot to be done, but it's not that nothing can be done. Okay, so this is encouraging. Things are changing. We have some targeted treatment, for example, for hypothalamic obesity. There are some medications available which are very difficult to prescribe. For example, GLP-1 agonists, we really struggle, with funding of these medications, but all this work to make this treatment more available, needs to happen, in the next few years. And rehabilitation, I don't want to say because it has been said multiple times, but it does work if started early, and all sort of rehabilitation, cognitive, visual, and, needs to be embedded, in the care of these patients. So we're doing already much, much better. Things need to continue on the molecular side. We need to be able to understand, the mechanism of the tumor, so we can hopefully, predict the behavior one day. And then there are already many targeted treatments that, are in trial. But hypothalamic dysfunction also needs to be a research priority. We were part of a working group with other European colleagues. UK is not Europe, but anyway, moving on with other colleagues to develop some international research priorities for endocrinology, and hypothalamic dysfunction was one of those, top of the list. Of course, campaigns to make people aware. The Head Smart campaign was a lot about headaches and symptoms of raised intracranial pressure, but you will see that when patients with the craniocaryingioma come, most of them will have not been growing for many, many years. So if somebody looked at the growth charts, maybe the tumor would have been diagnosed earlier. And then, of course, this is a recent success, and you all heard about it. And this is incredibly important for patients with brain tumors. So I think the future is looking, better than it was many years ago. Thank you all.